Well, Rocky, you're on. We cannot hear you, or at least I can.
Let's try that one more time. Good morning, everybody, and welcome to our second session. I'm going to go back real quickly on the slides. I want you guys to be able to kind of get a sense of our topic again and make sure we're all on the same page here. Again, I'm Rocky Romero. I'm coming to you guys from Albuquerque, New Mexico. For those of you that are joining me from New Mexico, again, this is a co-sponsored training between the National Hispanic and Latino Mental Health Technology and Transfer Center and the Office of Peer Recovery and Engagement through New Mexico. So thank you to Nathan and to Alicia there for getting us set up and for supporting these trainings. We have 2 more trainings in this series that will be coming up in October and then into November. And then we're hoping to have one early in the spring for suicide prevention. Again, thank you for joining us. Today we're looking at cultural values and idioms of distress in the Hispanic and Latino populations. And this is specifically for peer worker and giving that perspective and hopefully that application in this discussion. And first of all, I want to recognize our peers out in New Mexico, especially, and I know not only New Mexico, but around the country, this is a growing professional body that's developing, and I'm very thankful that we're able to help develop that professional body even further by giving you guys some ideas on ways to fill up your toolbox and ways that you can better and more culturally appropriately train and provide services for our Latino populations. Again, as was said, we use really trying to use affirming and respectful recovery-oriented language as we move forward in these presentations. And as was noted at the beginning, I just want to say this again, the MHTTC is available for providing consultation, training development with specific agencies that are serving Latino and Hispanic populations, and really want to provide some technical assistance to those agencies that may need that. So please don't hesitate to reach out. These trainings are funded through SAMHSA and do provide a really good resource. So for today's work, we're going to build on last month's presentation and really start to engage more in depth and specific cultural application of engaging Latino populations and really starting to pay attention to one, the cultural values and idioms of distress in the mental health treatment, and how you as a peer have a critical role in helping to facilitate that and helping to connect with those individuals at that cultural level. And I think you'll see what I mean here in just a second. So part of what we see here through our learning objectives is we're going to describe some cultural concepts of distress and values unique to the Hispanic and Latino communities, and some of the language that we hear today or that you hear today I'm sure will be familiar to some of you from New Mexico, especially that have lived here as native New Mexicans, and those of you that are coming to New Mexico from other parts of the country and practicing in New Mexico now and living here. We definitely want to provide you with a baseline of information and language and tools that will help you hopefully further connect and provide services that are appropriate. We're going to look at, again, cultural idioms of distress. We're going to also look at how that plays out in mental health treatment and again, understanding some of the challenges that the Latinx population may face. The third is to demonstrate and identify unique concepts of distress. And again, how do we start to identify ways that as peer support workers, you can facilitate a certain level of comfort with people that are coming to you because they feel connected to you as a peer support worker, because you may have experiences like they did, whether addiction or mental health. You may look similar to them in terms of your cultural presentation and cultural markers, right? Like skin, hair, those sort of things. And more than anything, even for those that do not look like the clients that they may be serving racially or ethnically, if you're coming from a place of genuineness and you're coming from a place where you've done your homework and you're aware of some of these cultural idioms of distress and ways that we can appropriately treat the Hispanic and Latino population, again, through a culturally responsive lens, I think you'll still be able to connect with people and be able to provide a unique support for those that are seeking your services. So Cambridge, just the Cambridge Dictionary provides cultural responsiveness definition as the ability to understand and consider different cultural backgrounds of people you teach, offer service to, etc. So what we want to be able to do is have you as providers, right, and as excuse me, as peer support workers, you're providers that provide a very unique skill set to helping clients get engaged and initially really feel connected during that intake into the therapy session process. So I always say this, and I said it last month, is I see peer support workers to this clinical process as a very important conduit, if you will, that will help facilitate and engage clients and potentially have more successful outcomes through that engagement as well. So cultural competence, and we firmly believe at the MHTTC that cultural competence is not a check mark or a box or a training that you scratch off of your list and you're good and then you move on. It's something that you have to continuously train on. Now that we're going through some of the changes in our society and some of the racial and societal discourse that we're seeing, it makes it even that much more important for us as providers to engage and be aware of other races and other cultures, other ethnicities, experiences, because it's becoming such a cornerstone of topics and discussion. And really, I think it's our job to validate those feelings of discrimination when people of color present as such in our office. And there may be no other way to describe the distress that they're experiencing, but maybe it's because of discrimination. Maybe it's because of the lack of cultural competence, that they've been treated certain ways in different institutions, and that's playing out emotionally like we know that it can do. So CROSS talks about cultural competence, and then again, U.S. Department of Health and Human Services use these two definitions. So CROSS, a set of congruent behaviors, attitudes, and policies that enable a system, agency, or group of professionals to work effectively in cross-cultural situations. So let me just say this, even myself as a person of color, I still, and coming from the communities that I do, I still have to do my homework. I still have to attend trainings and learn of other cultures, learn of other experiences that may not be of my own. And that's a continual growing process that we must engage in to address blind spots in our competence areas. Again, Department of Health and Human Services, cultural competence is a dynamic, and let's focus in on that dynamic, right? So changing, shifting, not static. Ongoing developmental process that requires a long-term commitment and is achieved over time. So please, for those of you peers that are just getting into this work and those of you that have been in this work, please don't stop getting the cultural competence. And you see that part of the required continuing education for a lot of licensure levels in the state do require the ongoing cultural competence training as part of the CEU requirement for your hours annually or every 2 years. So that's saying something. And I think in New Mexico, we've in many respects set the groundwork for a lot of other states to follow in terms of the cultural competency requirement that our licensing bodies have required, which I think is really something to be proud of. Oh man, I'm sorry about that, guys. I just locked myself out of the screen here. So part of the continuum of cultural competency, again, cultural destructiveness, and these are coming from the red or the left side of the screen that you're seeing, kind of looking at your computer, all the way to the right. It kind of goes through these different levels of competency, right? Of learning, of being aware, of exploring, and the red, which is kind of the critical area, right, is being forced to assimilate or coming from a group or a position maybe where in your childhood or in your upbringing, you were really taught that groups and people of color should be separated and they're different, and this group of people is really bad and this group of people is really good, and all these different things that we're taught as young children. And I ask you for 1 second just to think back, what were those messages that were taught to you by your parents, by your caregivers, by your loved ones? And not to say that our loved ones, and I always say this, I pause usually when I say this, most often our loved ones and our ancestors and our family, our parents, were not teaching us the ways of culture and race to be um, to be discriminatory against others, right? They were teaching you what they learned from their parents, and that may be something that is up to us to change, right? If they were teaching us that this group of people is good, this group of people is bad, stay away from that group of people, then potentially we have some work to do as practitioners right now that looks at this continuum of cultural competency development, right? If we're very much in the red area here on the left and stuck in um, people should be treated differently and we're better than them, and then you really have some work to do. And I really engage you and encourage you to seek out supervision around that. It's okay to have it's not okay to practice and put into practice racial biases and discrimination, especially in the work that you're involved in and engaging in. But it is okay to recognize that you've been taught and you believe certain things around race and racism, or the reasons that you maintain stereotypes in your current belief system. Right, those are things that we encourage you, and I hope if there are clinicians on the call that supervise peers and on the training, the webinar, I should say, that supervise peers, this is definitely an area to explore in your supervision of peers. And I firmly believe that in order to continually develop our peer professional body, we need supervision, 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 not only to help them deal with some of this development, but also their own professional development and maybe, again, some of their own recovery from mental health situations and issues and or substance use. So, we look at this from the cultural destructiveness, cultural incapacity to cultural blindness, right? Where some of you may see cultural blindness and have heard cultural, looking at it from this kind of colorblind ideology. Colorblind ideology is just as dangerous in many respects as racism is, right? Saying that I see no color, I only see people, I only see human beings, is really dismissing peoples of color, their experience as an immigrant, as a parent, as a person of color in an institution. You're ignoring all of those things and saying we're all kind of equal and we're all starting from the same point, which ideally we wish we could say that. That's not the case, and many of us know that and recognize that, right? So be careful of saying I'm colorblind, I don't see color. In some respects, in groups of people of color, they may see that as being disrespectful and not really considering their color of skin and all that comes with that experience in the United States. Cultural pre-competence, cultural competence, and then cultural proficiency. So you're working towards that. So what I would ask each of you to do is really assess where you sit within this kind of continuum and be honest with yourself. I'm not gonna, call on folks or ask folks, but just get a sense for yourself. Where am I kind of fitting into this, into goods continuum of cultural competence? Where do I sit right now? Right? And the good news is, if you're willing to be open-minded and to engage in learning, you can move through this continuum. If you're not, and you're kind of going to be stuck in old ways of thinking and not the cultural values or belief systems that you were taught, shouldn't be considered and looked at carefully. But sometimes we have to be the person in our ancestry kind of lineage that changes some of that, right, for our families and for our future kids and for our future generations. Anyways, very good continuum of cultural competency that I think is a really good tool, and it's a really good tool for use in supervision for those of you on the webinar who are working with peers or supervising peers. And then again, for peers that are on this training, it's really good just in private, right, to kind of look at this and be honest with yourself. And be open to really where you need to develop and where you may have some blind spots in your practice. This is just another tool of, again, core elements of cultural competence. So really kind of understanding and really being able to use this as a tool. And this is, based out of SAMHSA in 2004, that really looks at the multi and many levels of development that you have to consider when, again, you're looking at, each of these different races or ethnicities and teaching around awareness, cultural knowledge of behavioral health, and then skill development, and then looking at those at all the different levels when we say individual staff level, clinical program level, organizational or administrative level. And then I think one or two more aspects of this that I would include are explicit and implicit cultural competency, right? Meaning that implicitly and explicitly, are we looking at both of those specifically for our development of cultural awareness, right? So what does the makeup of our staff look like in terms of people of color on in positions of leadership, our clinicians, people of color, and then so on and so forth, right? And I know that can't always be the case given some of the availability and short staffing that maybe we have in certain areas, especially in New Mexico, where we have pockets of rural populations that sometimes are hard to fill, again, always with people of color. So this is just another tool that gives you some kind of institutional vantage points in your cultural competence development. And it's something that you can take back to your agency now. And for those of you that do have an interest in really taking this to your agency and helping them develop from your peer role or your clinical role, if you're a clinician on the call, to help the institution that you're working in develop even further. So part of the principles for culturally competent treatment, again, for serving the Hispanic and Latinx populations, is including cultural values in helping to gain knowledge about the culture itself, right? So identifying those cultural values and then having a certain understanding of the cultural history to a degree. I think I initially last month went into some of the discussion. I hope some of you may be able to join us tomorrow. We're having our first part series for racism, discrimination, and those intersections, looking at the Latinx populations in mental health. And we engage this much more of looking at some of the history and how some of this has developed. Definitely be aware of your own attitudes, beliefs, biases, and assumptions about other races and cultures or ethnic groups, or even other immigrant populations or immigrant populations specifically, right? Some of us have a certain view of immigrants coming to this country, whether we see that legally or illegally or put them into that dichotomy, or we think of people coming here or not that are seeking asylum from violence in their home countries, right? We have to be very aware that a lot of people have different views of that, especially given some of the prisoner camps that we have right now for people who are immigrating here that are considered illegal immigrants, right? In air quotes, as you may see me here on the screen. So just understand where you sit with some of those things and how that impacts your ability to provide services ethically, without being biased, without being discriminatory in any way. We definitely have to understand the different cultural idioms of distress that may be exhibited and or exacerbated by an agency for people of color, especially for the Latinx community, as we're talking here. So some of the things that we covered last week, or last month, looking at the cultural values for Hispanics and Latinos, is A through F here. So familia, or family, respeto, or respect, personalismo or personalism, personalization of the experience, of your communication, of your contact with people, confianza or trust, espiritualidad or spirituality, and then we have traditional healing, or more specifically in New Mexico or in this region, curanderismo that we'll talk about. Or of course, there's other indigenous healers that we have from our indigenous and native communities as well. So we covered familia, respeto, and personalismo last week. This week, or last month. This month, I'm going to focus more specifically on the last three: confianza, espiritualidad, traditional healing, and curanderismo for the next couple of slides here. So confianza or trust, right? In this, looking at it from the lens of a cultural value system for Hispanics and Latinos, or the Latinx population as the new term that's evolving in society, a form of mutual reciprocity, having faith that individual will help you to the best of the ability based on the relationship. So a lot of trust, if you can understand, is based on the very same anchoring points as any relationship in your life that you have trust in, right? So that may be being transparent and being honest with people, that may be showing compassion to people, that may be doing what you say and saying what you do, so being reliable to people, right? So all those factors, and think about your own relationships of how do you build trust in relationships. There's mutual reciprocity for learning and teaching, right? And there's also a mutual understanding of support. In this case, the trust is much more important, excuse me, than the reciprocity of support, right? Because in many respects, we don't want families to have to support us, right? We don't want families to have to come to us as providers or for providers to have to go to families for mental health support. That's kind of backwards. But the reciprocity is much more in the genuineness and the trust and the relationship. Many people from Latin communities, especially if we have individuals from those communities or populations that have immigrated to the United States, there's a certain element of fractured trust that comes into play with the systems that they've been involved in through their experiences with the government and with other systems and institutions. So we have to be aware that in many respects, we may be in a position, and you peers, I can't stress this enough, are in a very strong position to be able to regain people's trust and really build trust because of genuineness, because of shared experiences that you may have with this population or with the client that you're serving. Some disclosure, I think, is appropriate. That's always a fine line, and you have to definitely report back to your supervisors. And I'm talking with peers and master's level providers as well. We tend to, in the addiction world and doing a lot of matrix training, self-disclosure around addiction and recovery is kept to a minimal to a degree, but it depends on the model that you're using, evidence-based or best practice model that you're using. And it also depends on your agency and what type of relationship they want to develop with the client that they're serving, right? In some institutions and agencies, there's a very business-like relationship that starts to happen, and some things are very black and white. In others, there's the ability to develop more connectedness and more therapeutic alliances through relationship building. So be aware of your agency, your philosophy. Really discuss this relationship building, and always, I think that's the one thing that I would say with peers is be aware of your boundary setting, right? Be aware that building trust does not mean that you have to step over the boundaries of providing services that are not allowed to be provided through your agency. Like, for a very basic example, providing a ride to somebody when your agency says you can't, but you've really developed a relationship with the client and you trust them that they wouldn't sue you in the sense of you get in a car accident something of that effect, right? And believe me, I've seen that in my practice. Anyways, it's just really having that discussion with your supervisor so that you know where that boundary also lies, and continually having that discussion. So spirituality, or spiritualidad, is the term of expresses a belief that individual cannot do much to alter their fate. Now, we have to be cautious in this area too, because spirituality and religion may be two separate discussions, right? And you have to, as an agency and as a peer within an agency, understand how you describe that to people. We would much rather, from this training's perspective and the MHTTC, approach this from spirituality rather than religion. Religion at times tends to bring in some political overtones, and even some power and control, certain expectations, and it may impact your relationship. So having a more broader discussion around spirituality can help engage clients of Latinx communities and Hispanic communities much more effectively. We also see, and there's a belief that having an illness can be a direct result of a spiritual punishment, in a sense, right? And that's historically coming from some of the belief systems that can be connected to certain religions, and other things that you just have to be aware of, right? That you may be in certain engagements with clients where they believe the illness that they are experiencing may be a direct result of their bad behavior or their family's historical bad behavior. So really be aware of that and engage that and have that discussion. It may be an important tool that you lend to them, where you're lending them a vision of hope and changing and reframing that, where maybe you do impact their thinking, and you can get them to shift that to a different approach or a different lens or a different frame, as we've talked about. Definitely, it can be useful. Spirituality, it can be useful in the sense that, and you know, through Medicare and through the MAD program here in New Mexico. New Mexico is one of the first 8 states to be able to approve going to traditional healers and getting insurance to cover some of those costs. So I think it's really important to tap into that and to ask about that. Sometimes you see the clients that are more cultured into Western and American and US society will start to get away from the spirituality or the traditional healers and more into Western medicine, right? So our psychiatrists, psychologists, counselors, and I think it's okay to remind them that if they really at one point or another felt connected to traditional healers or spirituality in their home country, that in New Mexico or in the region, if you do have access to that, that you can connect them potentially to a traditional healer if they feel that that may help them in their journey of recovery from mental health or you know, addiction. So looking again at traditional healing, curanderismo is an indigenous method of cure, again, that many of the traditional illnesses, so susto, empacho, or mal de ojo, some of the terms that you see here, you know, are really kind of looking at, so susto, fright, for those of you that you know, don't speak Spanish, or empacho is kind of like feelings are stuck, or they're not kind of passing, and you're kind of stuck in this rut, if you will, and emotions are stuck in just kind of a loathing in a certain emotion, if you will. Mal de rojo is a symptom of somebody showing envidia or jealousy towards, usually it's towards a child. And actually my mother experienced mal de rojo, and my grandmother took her to several doctors, you know, Western medicine doctors, and they couldn't figure out. They thought it was colic, and then they thought that she was experiencing, you know, jaundice and all those things, and it wasn't any of that. But she had a fever and it wouldn't break, and you know, she was very close to passing away, having a fever for so many days. that they finally took her to a curandera, and they did the egg ceremony. And you know, that whole ceremony is probably a better explanation from our traditional healers, who maybe we can invite to give you guys more of a specific discussion on what the traditional healing methods are. We have a lot of those with the MHTTC conferences and seminars when we have those in person, that we've done, where we've actually invited curanderas up on stage to give a live presentation of some of these cleansings or these practices. So sometimes the practices are secretive. Sometimes, again, these limpias or cleansings are meant to get rid of negative forces, or espíritus, or spirits, as some people say. And sometimes traditional healers may go into people's homes and with a sage bundle, go through, light the sage bundle, and say prayers as they go through somebody's home, and then go through the smudging ceremony or limpia with the individual, where that individual gets some of the sage smoke and rub it throughout their body. And it's very symbolic in meaning, right? So those of you that may not come from a Hispanic or Latino community, or have ever experienced this, may see this or look at this as foreign or different, or I don't know how I sit or feel with it about this. So I think those are the reasons we're wanting to engage you in this training, and I'm glad those of you that you know, signed up and attended for today are here, because it's really a primer for you, those of you that aren't you know, really aware of some of these practices, to just start to be aware of how this may help a client who you see is stuck or unable to move forward. Even in the addiction world, it comes into practice and play a lot. And then we have the hierberos, who are herbalists, or people who practice the use of herbs for healing rather than pharmaceuticals or Western medicine. They tend to go to the natural herbs that are grown in our communities, native to New Mexico, parts of Texas, and other parts, of course, Mexico, and other parts of the world, not just here in this region. And it happens all over the country in different pockets. If you're starting to pay attention, certain communities will have these healers that they go to, in many cases, before they go to you as a counselor or a peer or a clinician. So be aware of those, and really be open-minded about those. Some people that may not understand these cultural values or practices may see it as witchcraft, or may see it as something that is evil. It's really just, and I say just, but it is healing entities that has been rooted for hundreds of years and centuries, that has promoted healing in our culture and our generation. So I really encourage you, keep an open mind. Please don't put us in a category that you other these practices and create distance between the opportunity to really help people that may see this as an entity that heals them and really provides some support to them. So I'm going to go on. We're looking again, cultural kind of aspects. Some of the concepts that we introduced last week, and I want to just kind of touch on a little bit. I think those of you that do sign up, and I hope you do. There's still time to sign up for our presentation tomorrow. I will be talking about racism, discrimination, and again the intersections of mental health. But when you're looking at working with Latino and Hispanic clients, you have to look at their acculturation levels, right? Acculturation levels meaning, is this a first generation family that is here in the United States? Are they second generation, third generation, fourth generation? That will to a degree tell you the level of acculturation. Acculturation means the ways that people pick up the customs and practices and even beliefs, culturally and otherwise, of the dominant society into which they're immigrating to, right? So what we see a lot of in young people and adolescents is that adolescents, a lot of times, they acculturate at a much faster rate or rapid rate than their parents or their grandparents do when they first immigrate to the United States, because of technology, because of social platforms, because of their exposure to school and other social experiences. You have to definitely assess for discrimination. And that's what I mentioned to you all earlier, is when people present with some of the symptoms that I just mentioned or briefly mentioned in the last slide, around empacho or nini limpias, sometimes those symptoms can be caused, and I really believe this, we haven't really named this more accurately, I think, as we are trying to do today, given our climate in our society, is that we have to really validate for people the symptoms they're experiencing from racism and discrimination. And I'll say that again, we have to validate for people the experiences and emotions and physical symptoms that they may be experiencing that may be caused from racism and discrimination, right? And that may be anxiety, that may be paranoia, that may be PTSD or post-traumatic stress, that may be impacted their adverse childhood experiences as they immigrated here as young children and now hold certain beliefs or have experienced certain discrimination or racism, right? So that's important. Same thing with oppression, and then of course the stigmas that we see. Unfortunately, folks, you all really, a lot of our clients are going to come to our agencies given the way the leadership in our country talks about immigrants and talks about people of color, talks about illegal aliens, and really presents people of color, Latino and Hispanic people of color in this seminar specific content in a very negative light. And those individuals may be initially experiencing distress from that, because language and images that people see in their day-to-day experiences matters and it impacts us. So be aware of that, and be aware that that may be something you have to help clients really work through as they kind of move through this experience. So I'm going to go ahead and cue up this video. It's a short video. I just want to kind of let you guys see this for a second so that you can experience kind of the conversations we want to have and engage in, and these will again build into our conversation next week. For some reason, when I have this in PowerPoint slide mode, the video isn't showing up here. So I'm going to go ahead and play this, and then I'll get back into our PowerPoint slide there. So we're going to watch probably about 2 or 3 minutes of this. Okay, so bear with me.
I think the Latino identity is pretty confusing to me because oftentimes I find it in a little checkbox on a form, and I'm confused on whether I should put Latino or Hispanic, but I'm Mexican.
As Latin Americans, as Hispanics in the US, there's a community that gets built regardless of which specific country you're coming from.
And our history is a history of African people, indigenous people, Europeans, conquistadores, all these different people colliding, many times not with their consent. So that informs all these loaded issues people have.
It's like navigating 3 identities. If you're from the States, you're American, you're Black, and you're Latina. And furthermore, wherever country that you identify in coming from. And that's a lot to navigate.
But at this point in my life, I actually don't identify as Guatemalan, and it's something that I guess a lot of like young immigrants sort of feel, where there's this saying like ni de aquí ni de allá, not from there, not from here.
In trying to blend in with the culture in America, I gave up a lot of what I grew up with. Maybe I saw it as something that was kind of shameful or in the way. I wanted to dress like my friends in America. I wanted to talk like them. I wanted to be like them, listen to the same music. I started listening to country music.
I got all these crazy questions like, did you come here in a canoe? And do you know what snow is? And do you live in a hut in Puerto Rico?
I thought my name was Spick until I was about 13. And that was my first awareness that race was an issue.
People say, oh, you look like a white dude. In some contexts, not in all contexts, depends where I am, depends who I'm with, depends whole lot of things. Depends what language I'm speaking. But however I look, when I leave my name, I can't get a phone call back about an apartment in New York City. And this isn't like 10 places I call, this is like 30.
And I remember telling a kid one time, I was like, let me tell you, the Ku Klux Klan comes here and they see your last name, you're going too, bro. You know, and the kids are like, what are you talking about? And it was like a big thing.
People generally, unless I speak Spanish, people assume right away, that I'm African American, that I'm Black. It's just one of those things. It may be the deep voice, it may be the color of my skin.
Because I talk white, I'm not Dominican, or I'm not Black, or I'm not Afro-Latina, or whoever people perceive me as of being. And that hurt, and that still hurts.
Because one of my daughters is lighter than the other, they had Blackness issue. And I remember my oldest daughter telling my youngest daughter that she was Black and that her hair, she said something. And I remember crying like immediately, like, oh my God, no, no, no. And I had to sit them down and talk to them about our roots and that everything that they learned from the family was wrong.
I feel like I wanted more of my culture. I grew up, there was a point I stopped speaking Spanish to her, and I still don't speak to her in Spanish. So I feel like something was lost, and I don't know if it was just because she was busy raising 5 kids and didn't really think about culture in that way and how I would come to identify myself.
Growing up, like this, as as a young teenager, I told people I was Puerto Rican, which is completely, which is right. But at a particular point when I became a little more politicized, I was definitely more of a Black nationalist than I was a Puerto Rican nationalist. Maybe because the concept of Black nationalism and the Black liberation movement is so much more accessible. There isn't a language issue. So yeah, I totally was reading Malcolm and Marcus and James Baldwin and Huey Newton before I read any of the Puerto Rican nationalists.
Either you're Black or you're white, and if you're like kind of in the middle, you kind of like don't want to be in the middle. A lot of us want to be white, but we're still brown. We're still color. We still have color. We're still, according to what the institution is telling us, race is based on your skin color. So you're like, I'm brown. So that's kind of like where it came. Like I'm not Black. And I'm not white, and I want to be white. So I'm kind of brown, and this is kind of like a thing that's there.
If you are closer to being white, you are supreme. If you are not, you are less than. And to me, that's how I understood it. And that's why I think it's very important that Latinos who look like me say, you identify as Latino, cool, Colombiano, cool, whatever else, but you benefit from light skin privilege. The fact that you have ojos claros, people want to fetishize that, understand what that means. However much I might want to say, oh my gosh, I'm so special because I have green eyes. You're perpetuating white supremacy by running with that.
I'll talk to a young girl, a young teenager, and she'll say, I'm not white enough to fit into mainstream society. I'm not Black American enough to fit in that, in that faction of society. And I'm like, but you know what? You're the best person to be kind of like a connector between both, because in you is everything. And being Latino in an American kind of New World way is basically being a physical embodiment of how America began as we know it. So you're every woman. So for me, being Latino is being phenomenal.
All right, so I'm gonna go back to our slideshow, and I just want to ask by show of hands, you guys had your little hand there. How many of you, especially those of you from New Mexico, and others can definitely answer as well, if you've experienced in your own experience as a person of color, have you experienced this kind of dichotomy or difference where you feel like you have to either belong to one side or the other? And when we see this a lot in northern New Mexico or in this region, I think, is this whole concept of, oh, I'm Spanish, I'm not Mexican, right? And the gentleman, again, the one that said he has blue eyes and he has privilege, is really describing that whole separation, right? Many people from Latino, I mean, from Hispanic and Spanish communities in northern New Mexico and in the region of New Mexico, and in this region of the United States, tend to want to be more aligned with Spain and Spanish, rather than Mexican. And again, that really identifies this black and white dichotomy that we get into in the United States. So the question again, how many of you, just by show of hands, has ever felt that in your own family or your own experience, that you don't know where to belong, or if you're brown or you're white, or you're where you're supposed to be, kind of, you know, feeling confused at times? Anybody out there feel that by show of hands? I think I can see the poll here if folks are answering it. Let's see. Maybe and Mari can share that with us as she gets some results. But we're going to go ahead and move on. I just kind of want you to think about that, and more specifically, think about the response from your clients, right? Individuals from this region, from New Mexico, or from Latinx or Latinx communities, who may be experiencing all those things that those individuals just shared with us, right? And it becomes very emotional for people. And a lot of times, if you're not from a community of color, and you're, you know, from a dominant group or a white group or Anglo group, however you label or self-identify, sometimes you may not understand what that experience is like. So that's why we kind of share some videos with you, share some real life experiences where people are sharing that. But I think even in your own agencies, as a group supervision exercise, for those of you clinicians on the phone that are supervisors of peers, I think it's really important to have that discussion, right? What is that experience like for people? So now we're going to get into some of the cultural idioms of distress and looking at cultural explanations. So idioms of distress are the symptomatology, right, that people express, maybe collective, maybe a group of people or a community, shared ways of experiencing and talking about their personal and social concerns, right? Labels that are specific to the explanation, cultural explanation, or some of the perceived causes would be labels, attributions, or features that kind of help explain those symptoms more specifically, or again, the root or etiology of those symptoms, illness or distress. Okay, so really understanding those two concepts is really important for the next several slides. And just so we're kind of looking at time, I have about 10 till 10 o'clock. I think we'll probably go just to shortly after about 11, and then we'll have about 15 or 20 minutes for some follow-up questions, and then any questions from the audience that and Mari can possibly help us facilitate here. So moving along, again, specifically, and this is which is really cool, is now this is included in our DSM-5, right? The Diagnostic and Statistical Manual, APA, and it's looking at these cultural syndromes, and this is really now a part through the Cultural Formulation Interview. And for those clinicians on the line, and even for you all as peers who may be doing some general case management intakes, or doing intakes for general needs around peer support services, you may consider looking at that Cultural Formulation Interview that's a part of the DSM-5, and consider adapting or working with your supervisor to adapt and include some of those culturally appropriate questions, or as clinicians, you as the clinician possibly doing the Cultural Formulation Interview as part of your assessment portion. So those, again, cultural syndromes are groups of symptoms and signs that can help you as a practitioner specifically identify the context in which groups are coming from different communities and expressing some of these distress symptoms and illnesses. So defining cultural idioms of distress more specifically, the ways in which a culture express affliction, right, or distress. Definitely idioms matter because the provider, it helps you to provide a cultural context and a culturally sensitive treatment approach, right? And you as peers sometimes I think are in much better positions to be able to, because of your lived experiences and similarity to the community members that you're serving, can help to bring these to the surface when you're talking in your multidisciplinary treatment team meetings with other clinicians, nurses, docs, you know, the whole team there. You can be aware of some of these cultural idioms of distress that and markers that people may miss. And now that you have this information, you'll be much better armed to be able to deal with some of these things. These idioms of distress definitely can be an expression of anxiety, depression, even dissociation or post-traumatic stress. And then with some of our, you know, adolescents and teens and even adults, we have to look at the adverse childhood experiences that they may have experienced during their immigration journey to the United States, to New Mexico, to whatever state they're living in the United States, right? And all that experience may encompass. Many of the clients that you may be seeing, unfortunately, it brings tears to my eyes to even discuss, and we'll talk about it more tomorrow in tomorrow's seminar. But you know, those kiddos and families that are imprisoned currently in facilities where they're not being treated, and now some of the things that we're seeing or that are coming out of there. And again, we have to really think about it, right? We have to be conscientious if these women's rights are being stripped and women are being, you know, medically treated and giving mastectomies and other things. If that's really happening, we have to be ready in our communities for the fallout of that distress and that trauma that women are going to be experiencing, and not just women, but the husbands and families that these women go back to and have to explain. Now we can't have children as a family together, right? Because of some of these practices. So that distress and that trauma is to me one of the symptoms that we're going to see from this year of 2020 and 2019 really playing out in the near future. Some of the idioms of distress: nervios or nervousness, a general state of vulnerability or stressful experiences. Definitely this you know, idiom may be experienced with other somatic symptoms, so headache or feeling butterflies in their stomach, stomach aches, general pain in different places of the body. You know, we have to just be aware that nervousness or anxiety in general terms can create other somatic symptoms that the client may present with initially, that we may have to dig a little bit deeper. Is this connected to discrimination and racism maybe that you've experienced? And starting to ask some of those questions. Ataque de nervios is really an anxiety attack, right? In English, an anxiety attack or attack of the nerves. Definitely is characterized by symptomatology that would include intense anxiety, maybe even extreme physical and body language that you may have to pay attention to, like crying or shouting or trembling. And it may be even evolved to verbal or physical aggression, is the way that we see some of the ataque de nervios play out in Latino and Hispanic communities specifically. And it may not necessarily be something that again, you have to do your assessment, and it always should be clinically determined if this is posing a risk to themselves or to other people, right? If they are starting to self-harm or starting to harm other people violently, then you have to appropriately make those you know, reports, and of course keep your supervisor in the loop and aware of what you're seeing and what you're observing if you feel somebody is experiencing this cultural idiom of distress. And then we have susto, and susto can, to me, be attributed to a lot of different experiences, from the immigration and the violence and trauma that people experience in immigration, the trauma that people experience through a violent experience or violence in their communities. And then also we see this also, I see this, and we can possibly see this through young people who are experiencing violence in their communities or in their youth cultural group. When I say that, sometimes we see Latino and Hispanic young men, and now more, unfortunately, more or increasingly, we're seeing young women of Latino and Hispanic backgrounds start to get gang involved. And we see when that gang involvement happens that sometimes when people are experienced at a young age to violence and criminal activity, they kind of get this fright, or they get this experience, and it may impact them. We've also seen it through other adult sort of situations where domestic violence and or violent experiences, obviously for women and men, but more prominent in women, and at least in my experience, may be experiencing some of this. And again, I think we have to just be aware of some of the somatic symptomatology that will present usually before we get deeper to the, past kind of the surface emotions and surface issues to the deeper emotional issues that this individual may be experiencing. So we're going to kind of take some time now and look at this last video. So you kind of look at a case application. It's 10 o'clock right now, so I think we're perfect timing. And we'll go ahead and I'm going to go ahead and change screens now, so bear with me for 1 second. And I'll go ahead and pull up my internet here so we can watch this video. So give me 1 second. Okay. So this one, it's 46 minutes. Of course, no way I'm going to play the full 46 minutes. I just want you to really kind of be able to get a sense of this person's experience and how she's trying to explain, that she's not crazy and that she's experiencing some things. And I think this will help for those of you that may not come from Latino or Hispanic communities and have seen some of the things that I described in today's training. For those of you that haven't experienced that, and for those of you that may still come from this region and New Mexico or the New Mexico communities, but may not have experienced these things in your own family or extended family, this will just kind of give you a glimmer into those experiences. Now, it's 46 minutes long, so I'll probably play about 5 or 6 minutes of this, and then we'll stop. I'll get some questions if anybody has questions, and then we'll have Digmati give you guys, or Edmati, I'm sorry, give you guys the poll question so we can end today's seminar. So I'm going to go ahead and play the video. I hope you guys enjoy this and can kind of get a glimpse of what we're explaining in today's seminar.
In 2001, the Surgeon General's report on mental health, culture, race, and ethnicity called stigma the most pervasive problem preventing members of all racial and ethnic minority groups from seeking behavioral health care for mental disorders. Several characteristics are associated with the stigma of mental disorders in Latinos. There is a negative cultural connotation associated with mental disorders. Stigma is heightened by immigration and acculturation experiences. The stigma of having a mental disorder is one of the most significant obstacles preventing Latinos from seeking help. Medication treatment heightens the stigma of mental disorders among Latinos. My name is Peter Bornacha, and I am a professor at Rutgers University. I'm delighted to be with you today to guide you through the DVD, No Soy Loco, I'm Not Crazy, Understanding the Stigma of Mental Illness in Latinos. As you will see, the idiom of distress of locura, or serious mental disorder, shapes how Latinos view mental illness. Avoiding the label of locura is critical for Latinos to maintain their self-respect and that of their families. Loco is used as both a noun and an adjective to refer to a person with locura. The overall learning objectives for this DVD are 1, to demonstrate how the stigma of mental illness manifests in the individual, family, and community in Latino groups. To demonstrate how therapists can empathize with their perspectives of ill individuals and their families. The idioms of distress that individuals and families use to describe their illness, the impact of symptoms on the family members' lives, and the diverse explanatory models and treatment pathways that individuals and families may use. Also, to show how the mental health professional can work in partnership with individuals and families to negotiate and implement a treatment plan that is acceptable. The following 3 vignettes provide examples of culturally competent treatment for Latinos. All the vignettes were developed by the psychiatrists who appear in the DVD. The patients are actors, but the content comes from real patients with whom the clinicians have worked. The vignettes have been altered to protect the identities of the patients involved. As you watch each vignette, carefully observe how the clinician works with the social and cultural issues embedded in the story. Pay particular attention to how the stigma of mental illness is managed as part of an overall culturally competent approach to treatment. The vignettes illustrate several themes that resonate through this DVD. One is the meaning of severe mental disorder in the Latino community. While the patients have displayed psychotic symptoms in the past, these symptoms are not always the most important dimension of their clinical profiles. Related to this is the stigma of locura and the desire to avoid that label at all costs. The use of nervousness or nervios emerges as an alternative to these more severe diagnoses for both the family and the clinician. Family relationships and the role of the family as caregiver and protector of vulnerable people are central issues in Latino culture. An additional important theme in these vignettes is the role of religion, both as a social support system for individuals and families with mental disorders, and as a possible source of distorted ideas for those with severe mental disorders with psychotic features. Diego is an 18-year-old Latino male who struggles to bring together the Latino and American aspects of his cultural identity. Born in San Francisco, he is bilingual in English and Spanish. He is tightly linked to his extended family, particularly his mother's family from Nicaragua. His father's family was originally from Cuba. Diego's acculturation as a second-generation Latino must be assessed in order to understand more completely his cultural identity. Diego grew up and still lives in the Mission District of San Francisco, a large Latino barrio or ethnic enclave of the type found in many large U.S. cities. Diego has had considerable experience with schizophrenia. His brother, who is 40, has been explicitly diagnosed with schizophrenia for many years. Family members suspect that Diego's mother suffers from schizophrenia as well. Her first husband left the family in the care of his mother's parents because of her bizarre symptoms, and then he disappeared. Since his grandparents died, Diego, his mother and brother, have been living with an aunt. Both Diego and his relatives are torn between seeing his problems as related to mental disorders or alcohol abuse, or both.
Diego, Mr. Salazar, I'm Dr. Barreras. I'm going to be the psychiatrist on the treatment team. Do you remember the events that led to the hospitalization?
I threw their chant at the wall, and they came and arrested me, so I punched the wall. I'm Jehovah. They're all jealous of me, I know it. They brought me here. I don't know why they brought me here. They can hear my thoughts from a computer in the control room in the nurse's station. It controls a hologram in my stomach.
Are you hearing voices?
You can hear my followers, don't you hear them?
Alrighty, so I'm going to go ahead and end that that one there. I think one thing that I want to just share with you all before we end today is also just keeping in mind that these, and the reason that we shared this this specific video, and then again, it's about 45 minutes long. So we want to give you all the tools that you potentially can also use in supervision with peers. So those are just a couple of vignettes that you definitely would be able to use, asking them to then provide you some feedback as you know, they're assessing cultural idioms of distress and really looking at some of the specific approaches that we can you know, start to identify for treatment planning purposes. But the reason we again wanted to bring this training to New Mexico and to the peers in New Mexico and into the United States, and open it up to you know, other states as well, is because we see peers as an integral part of the treatment team. I know that the video kind of starts to get into some clinical terms and those sort of things. I really feel, as myself being a master's level clinician, that peers play an integral role in the treatment team that can give us a lens to cultural idioms of distress and experiences that we as clinicians may not be able to explore or examine given our limited time with clients. Peers have much more connection and time spent with clients, at least in the organizations that I've worked with and for, where they're much more in tune with potentially some of the cultural idioms of distress that we've introduced here in our second seminar, and then also being able to develop ways in a culturally sensitive approach that will make the client feel more or more trusting, and may also make the client feel more connected to the agency, so that, especially in Diego's case, the last vignette there that we kind of introduced to you, people will you know, he'll be more comfortable given his paranoia that he's already experiencing, right? So a peer in this case, to be able to serve as a case manager and to be able to help to inform the treatment team on some of these cultural idioms of distress that Diego may be experiencing, is a huge piece that a lot of times we're missing with our limited time as clinicians in you know, interaction with clients moving forward. So I want to make sure today also that we bring back the slides on the on our presentation that's just giving you guys some more background relative to the you know, ways you can reach out to us. I want to make sure that you guys, you know, again, feel connected in the sense that you can reach out and feel as though if you need some support, if you need for us to provide a training to your agency, right now is a really good time because we have the ability to deliver it via webinar. If you want to wait and maybe request a training through our program, you know, once COVID restrictions kind of lighten and there's more ability to get face-to-face, I know that typically Latino and Hispanic populations tend to want to be more in direct contact, but these are the ways that you can help us, or you can reach out to us. Here is also the survey, and I'll let Mari talk more about that, and you know, go ahead and give you guys any of the follow-up poll questions that we need to do for right now. And if there's any questions that I could answer from the audience before you get off, I'd be more than willing to. So again, thank you for your time. Mari, I'll go ahead and let you take over. Thank you again.
Hi, that was wonderful, Dr. Romero. We have a question for you, and it's, is there a research to learn more about idioms of distress or dichos, positive or negative, with definitions and how to understand them in a clinical setting? Any research that you can share with us?
You know, I can definitely point you in the right direction, and reaching out to the center would be the first way to do that. So you see here at the bottom the email Hispanic Latino at mhttcnetwork.org. Please reach out and send that email and that request through the center, and then we can we have a more clinical applications training that we can provide to clinicians specifically at a master's or doctoral level that is much more in depth. This is kind of the primer of basic cultural elements that we put together and that we adapted for the peer population and professionals. But absolutely, we have a more in-depth clinical training, and with that, there's a ton of research that has gone into that and is provided as part of that PowerPoint training that we can provide to you. Great question. Thank you for that.
We also have a couple of comments about how great the presentation was, so that's for you to know.
Thank you. Thank you.
I wanted to ask everyone to please complete the survey and the evaluation. You can use the QR code, or you will be receiving an email with information for you to do it. And in a week or so, we're going to have a recording of this webinar and the handout in our MHTTC website and our YouTube channel. There's a lot of other resources in there, so sure, you can help yourself to those. And let me see if we have any more questions for you.
Sure. And let me also, I think I can, I'll just say it, or let me type it in here and see if I can give my email to people, but I'll say it anyway. If anybody wants to email questions or follow up or has a request for a follow-up training or seminar, and you're, again, please reach out to the center, but you're also able to reach out to me and I'll connect your request back to the center. But my email, the best way to reach me is so drrocky@gmail.com. So again, it's drrocky@gmail.com. If anybody has other questions. The last thing that I wanted to share with you, and it's okay, I think we'll definitely have more time for this, our next series, but I wanted to give those to you. I'm hopeful that all of you can join us for the next, the third part of this, and we'll get much more into the PowerPoints that are here in your handout section. But these 4 handouts are available at SAMHSA. What I want to really be able to do, and I think as peers and for me as definitely an ally for peers, I think trying to professionalize the peer movement and really give you all tools that will help you develop further is my intent. So these 4 documents are available through SAMHSA. SAMHSA has a pretty good training as well for peers that, again, evidence-based, and peer support work is becoming, again, more evidence-based and much more part of best practice approaches, which is awesome. But these 4 documents are part of SAMHSA documents that are created that we will cover next week. It's family and parent caregiver. There's a peer support one. There's a peer supporting recovery in mental health conditions, and then a peer supporting recovery for substance abuse disorders. You should have those 4 PDFs here in your handout section on the webinar site and be able to download those. I will go into those next week, but I wanted to just kind of give those to you this week and introduce them. If you don't join us next week, they are still very good tools that you can build upon and really review in terms of best practice approaches for dealing with individuals in those populations from a peer role. So again, I want to just reiterate, we value you as peers. You're important. Your time and your willingness to engage in training and further development is extremely important. So please reach out to us. We're here as a resource for you all, and we want to be here to support the peer movement even further. Again, I'm Rocky, signing off from Albuquerque. Thank you all for your time. I look forward to our next seminar together next month. Thank you all.
Thank you so much.
Thank you. Thank you, Mari and Christina. I appreciate you guys. Talk to you soon.